This conference will now be recorded.
Okay, so we've got camera, we've got fluids and pain, trips, getting equipment ready, and I see some really sensible thoughts about equipment, bear hugger, having an IO and cannulation equipment, some Clingfilm, trips again. Reference to analgesia, nasal morphine. Yeah, so I agree. A fast-acting opiate or opiate-like analgesia seems like a good idea. Probably something like diamorphine that we'd be using nasally. Burns guidelines, yeah. So I love the suggestion to get guidelines out. There's almost sometimes an embarrassment about referring to guidelines. I think we should be really proud of using guidelines. We know that none of us are perfect, coming up with things off the top of our head. We know, and if anyone's interested, the Checklist Manifesto is a good book to read about how human beings perform much better when they refer to checklists and guidelines. So I think that's definitely a good thing to have out. Great, okay. So I love all these suggestions. Trauma call could be debated. I knew that would come up as a suggestion or a request, whether that triggers a trauma call. I don't think it would be unreasonable to put out a trauma call. Your local protocols will specify what qualifies. Often it's only going to be mechanical trauma, so penetrating or blunt force trauma, but a lot of places will include sort of major burns with a high care requirement expected. And I certainly don't think it's an unreasonable thing to do, particularly in the middle of the night, to put that out. ABC, yeah, absolutely. That's obviously going to be when the patient arrives, and they haven't just yet. So I guess what's useful and what I was hoping to draw out from this is there a systematic way we can approach getting ready for this child? Because we're all raring to go with our ABCDE systematic approach to assessing and managing this child. But what about preparing? We've got a long list of sensible suggestions. We probably can't do them all at once, although we can try. Anyone know any systematic approaches to preparing for a blue call patient? Yes, I'm seeing assigning team members to roles. So yes, I think that's one definite category of preparation. So the people around us. Where it's like, yeah, so definitely. So that's going to guide us really about medication, I suppose to a lesser extent about equipment as well, but really going to guide us about medication. Yeah, so I agree. That's going to be an important step to take. Anything that might unify these things? Good. I was hoping there might be a deafening silence, because I think this is a really useful teaching point and something I wanted to share with you guys. Yes, I'm seeing more references to people. What I wanted to share with you was just a systematic approach to preparing for any blue call or trauma call. I actually use it a lot for trauma calls, because there's a lot to coordinate very quickly. So it's the PEDS mnemonic, so PAEDS. So I don't know if anyone wants to guess what the P is for. So we talked about assigning roles in particular. People, yep, definitely some people. So number one, assigning roles, assigning a team leader. I won't go through it in detail, all the roles we might have, but I'm sure you guys are familiar from having attended trauma calls and so on. But also thinking about other people you might need to be there who might not necessarily be part of your trauma call cascade or your blue call cascade. So I've had references to anaesthetists as a particular example, particularly if you hadn't put out a wider hospital call, might be somebody you wanted to have present. So that one's probably less guessable. So that's area. So why is it important to think about the area you're in? Are there any options as to where this child might be managed? Yeah, so that's a really great point about the resuscitator versus the bed. So I guess that's probably not a dilemma, particularly for this child who's 18 months. That's probably not going on the resuscitator. But we often forget to have the resuscitator ready for the smaller children who really might benefit from it. And I mean, people's preferences vary, but I know I'd much rather manage a poorly neonate on a resuscitator than on a bed. And if you don't have it ready, it's going to be really difficult to get it ready rapidly when the child has arrived. So that's a really good point. So about the right area, something resus or PDD, different bays, exactly. So we want to think about being in the right area. That's often important for trauma. There'll be particular bays, particular mattresses, would you believe, are often important and so on. So we really want to make sure we're in the right place. And often that's a conversation to be had with your nurse in charge. I agree, all else being equal, this is probably a child who's coming to your resus area. That's going to be my next point, St. George's PICU. Yeah, so clean versus dirty areas, that's definitely going to be something to think about. So we are not really using our standard PEDS resus room at the Royal London at the moment. We're using a suboptimal cubicle because needs must. Yeah. Okay, E, any thoughts what that might be for? So something we talked about, yeah, equipment, yeah, exactly. So I suppose we've touched on that with things like resuscitaires, and you guys already suggested various bits of equipment that might be particularly useful for this child. I like the suggestion of a bear hugger in particular. We'll come more to why that might be more important. D? Yeah, so any thoughts about any drugs that might be particularly important to get out? Because we can't get out everything quickly. That's not prioritizing. What's a priority to get ready? Yeah, yeah, yeah. Yeah, okay, I get it, guys. Yes, I agree. Yeah, so the first thing I would be getting ready in this situation would be an intranasal drug. So most places use diamorphine, some places use fentanyl. Either's fine, but to have that ready and start dosing it up based on the child's age and estimated weight. Okay, fantastic. The S is just send for help, so just reminding us of the importance of escalating and thinking of any particular specialists or seniors, consultants that we might want to inform even before the child's arrived. I guess there are particular blue calls where that's particularly important. We had a cardiac baby blue call in last week. We obviously had to start thinking even before they arrived at who we might want to be present. Okay, fantastic. So I hope that's useful. It really helps me order my thoughts in those precious 4 minutes you have before a blue call arrives about getting things ready. So I hope that's useful. Okay, but the child does arrive a few minutes later. This is Lucas. He is indeed 18 months old. Often ages and things get garbled on the blue call, but he is indeed 18 months. And the somewhat breathless ambulance crew tell you that he's pulled a tray of tea over himself. He's extremely distressed. He's just screaming. They haven't been able to get any obs other than RS 180 very briefly. He's accompanied by mum only, who's utterly distraught, which is why the child is on a bed by themselves, because she's in a little bit of a state. Yes, very sad to see, Mel, I agree. I think that's actually a very important point because emotions run really, really high in scald and burns cases. If we have time, I will tell you some stories about emotions running high in the resus room about burns cases, but important to pay attention to. And Tash, you've asked if any first aid has been given. That's a really important question, but mum's not really in a state to respond yet. Mel's curious what the front of the chest is looking like. Me too. So the ambulance crew tell you that the front of the chest seems to have been spared. It's really just the areas you can see at the moment. So the neck itself doesn't look involved, and it's just the right cheek, but not encroaching on the mouth and nose. Okay, someone to sit with mum, yes, and I think that's really important. If we don't have anyone present, that might actually be a member of the ambulance crew. Remember that you don't need to release them until you have sufficient people to manage the child. That's often particularly important in the COVID era where it takes several minutes to get suited and booted. I guess that's something we could have talked about in our preparation phase at the moment. Okay, what are people's thoughts? What do they want to do? Okay, so I'm hearing first aid and irrigation. Yeah, so worrying about involvement of the neck and nostrils. Just for sake of argument, I agree based on this stock photo, it would be a main concern. But let's say the neck and externally visible airway appears to be spared. Analgesia, yeah, I agree. So anyone want to do anything other than first aid and analgesia at the moment? Yeah, so I'm hearing about fluids and IV access as well. Yeah. Okay, lots of really good suggestions, and I agree with all of these things. What I find really interesting, now I know this is one of those situations where there's what you would do in real life and there's what you do in a sim or in a discussion, but I noticed there were lots of mentions of ABCD approach in the preparation phase. But I've seen loads of great suggestions here, and no one's mentioned an ABCD approach at this point, which I know everyone would do, I know. But I think the point that perhaps brings out is that burns and scalds are enormously distracting. So firstly, they often look horrific. Secondly, the child is screaming their head off. And thirdly, the parents, the carers, sometimes the ambulance crew and the medical team around are often really, really flustered. And it can be one classic case where even though we're so drilled into following our ABCD approach, we get distracted by various things people have mentioned, like analgesia, like fluids, like irrigation, like managing the family and so on. Now, obviously, I know ideally in real life we're going to be doing that in parallel. Yes, airway is going to come first, but we need to make sure we do all the other things as well, as George mentioned. Now, George, you're raising the point, and I agree with this. And again, I expected this would be an area of discussion about what's the priority here, the primary survey or analgesia. Are there any votes? It may be a trick question. Any votes who'd do analgesia first, who'd do primary survey first? Well, can people hear me? So I'm just wondering who would do analgesia first and who would do primary survey first. Yeah, okay, so I'm seeing that you've defeated my trick question. Yeah, so that's completely right. So obviously primary survey should be quick. People talk about 30 to 60 seconds, so hopefully it's not going to cause a huge delay anyway. But if you've got the people to do it, I see no reason it can't be done in parallel. The official guidelines say that, or at least the British Burn Association guidelines say that analgesia should come after the primary survey. But I agree with you guys. I think the two things should be happening in parallel, if only because a lack of analgesia in this situation is clearly going to compromise the usefulness of your primary survey. So really it's an adjunct here, isn't it? Okay, so I agree. So I think we're going to get some analgesia on board very quickly. We've talked about something like intranasal diamorphine. Do people know the dose off the tops of their heads? Anyone? Dose of intranasal diamorphine? Excellent. Refer to guideline. Yeah, so it's 0.1 milligrams per kilo. But yeah, thank you, Willett. That's exactly right. The way it's made up can be a little bit complicated because it's often the nurses will often dilute it to a set volume based on the age or weight of the child. But often as the medics, we just need to prescribe the dose. It's often something you want on the tip of your tongue in these situations. Okay, fantastic. So we've got some analgesia on board, and we move on to our primary survey. So we're crying plus plus plus. Chest examination seems grossly normal, really hard to assess the numbers just because of the degree of crying. We've already just given the diamorphine. Well done, Team Willett. But these are the sorts of numbers you're getting. Cardiovascularly seems well perfused clinically, although we can't pick up a blood pressure with all the thrashing around. Heart rate's very, very high. IV access, what do we want? Yeah, so thank you for bringing out those points. So yes, so firstly, we want to avoid burnt skin if at all possible. Yes, IO, as always, is an option if we cannot establish IV access. I would hope that wouldn't be necessary in this case. And obviously, in an awake child, there'd be considerations about giving appropriate analgesia when we did that. Number of lines, so I've seen votes for at least one and two. So this is a large burn, isn't it? And we, as a team, we've mentioned already the fact that this child's likely to have significant fluid requirements, perhaps not right this second, but certainly in the hours to come. There may well be a need for transfer. So there are quite compelling reasons why we probably want to have at least two rather than at least one good size lines. Does anyone know what a good size line means in a child? What colour or what gauge? Yeah, so obviously it's going to be a question of what we can get, as always. So the ideal would be pinks. So I think that's 20 gauge. But obviously I recognise as a fellow paediatrician the challenge that might pose, particularly in this child. And burnt children, obviously, often a lot of sort of shrinkage of the veins, and they're often very difficult to cannulate, so I recognise the realities of the situation. Okay, child's alert and clearly very agitated. Oh, that sounds bad. Whoops, I hope everyone can still hear me. But moving 4 limbs and the pupils are reacting normally. Really important to remember our E in burn situations, so they need a full inspection, as you guys alluded to right at the beginning. I agree, pink would be a heroic effort. And yeah, jugular access, well, I have seen done in similar situations, but we're going to leave that aside for now. We're going to remove all the child's clothing and jewellery. Jewellery we obviously don't want to restrict, limbs and so on. In case of swelling, clothing can stick to wounds, even if it is adherent. The guidelines are actually that we attempt to remove it because it's likely only to be stuck to dead skin. And we want to keep the child really warm, so that's why I love the reference to a bear hugger really early on. Okay, fantastic. So analgesia we talked about a little bit. Okay, so I completely agree. Something like intranasal diamorphine is going to be our first line here. But any other routes to pain relief and comfort for this child and their family? Any other suggestions? Yes, I agree with play therapy, a really good role for them in this sort of scenario, I think. I agree with simple analgesia in the form of paracetamol. You could give it IV, probably not awful to give it enterally in this situation, small volume. What's PR? That is in route of paracetamol. Okay, anything else? Yeah. Oh, and covering, Sarah, you've mentioned covering the burn. Yeah, agreed. So often, air moving over the burn extremely painful. Probably not wrong to use Clingfilm at this stage, but any sort of non-adherent cover, even if that's something quite loose and dry, is probably acceptable as well, just because we know we're going to have to further assess this burn in due course, but no problem with using Clingfilm. Okay, yes, I think we've got most of the main points there. Oh, irrigation. Yeah, we had that earlier on, didn't we? But remember that irrigation, as well as a form of treatment and a way to improve, an evidence-based way to improve the child's prognosis, it's also an excellent form of analgesia. And in fact, something we might want to do is actually irrigate for longer than the minimum required time, solely for reasons of pain relief if it isn't making the child too cold. Play therapy, not to forget the simple analgesia, and you guys haven't. So things like paracetamol and ibuprofen. Entonox, obviously not for this child, but for a child who's old enough to use it, might be really useful as well. And then ongoing pain relief. So important to remember that when we give something like intranasal diamorphine, unless it's for short procedural relief, it implies the need to give further strong analgesia in an ingoing way. And Victoria, yes, there will be tips on the practicalities of irrigation coming up. So I think of it almost as in when we treat hypoglycemia, we all know about giving a bolus dose of dextrose, and we all know that the pitfall is that people give that bolus of dextrose and then forget that you need to then give a steady flow of dextrose to that patient, whether that's enteral or whether that's an IV dextrose infusion. It's often forgotten. Similarly with the intranasal diamorphine in this situation, remember that there's likely to be a significant ongoing analgesia requirement. Now, it might be that the nature of the burn is that you can cover it, you can give simple analgesia, you get them over the fear of arriving in A&E, which is potentiating their pain, and the simple first aid treatments really get their pain under control, and they don't need ongoing opiates, and that's great. But I think we need to at least be ready that they might, and that might be by giving them aliquots of IV morphine, again, something like 0.1 per kilo, or even if in a really painful situation, setting up an infusion, thinking about PCAs, thinking about anaesthetic support if needed to do that. So just things to think ahead about. Lovely. Okay, now we talked a little bit about first aid, and there were some really good suggestions a few moments ago from the group. So perhaps asking the SHOs in the group particularly, who wants to take us through a little bit about first aid for a burn? And if you're feeling really brave, you could turn on your microphone and talk us through it. Any volunteers? Yep. So agree with removing clothing. Agree with a non-adherent dressing, probably to come a little bit further down the road. Yeah. So I want to hear a lot about irrigation. So when I was quite junior, I was a little bit dismissive of irrigation. I kind of thought, well, often when I've been taught about irrigation, I've been taught it's a way to cool down the burn rapidly, and that's what helps the healing. And I thought, well, that's clearly nonsense. If someone's been burned 5 minutes ago, let alone an hour ago, the heat's going to dissipate. It's not going to cool things down. It just seems a bit silly and a bit too first aidy for the hospital to be doing. But it actually has great evidence-based value, particularly for big burns. There's some debate about smaller burns about its prognostic value. But certainly for big burns, it's been shown to really be very helpful. And that's not by dissipating heat. Of course it isn't. But it seems to have effects on slowing the release of inflammatory mediators and reducing the propagation of cellular damage within the tissues. It's been shown in animal models. It definitely works. And the other great benefit to it is the analgesia. It's often done wrong, and what I hope to be a key learning point from this session was how to avoid the pitfalls in irrigation and how to do it right. So you're already avoiding many pitfalls because you're telling me the absolute correct length of time to do it for, which is 20 minutes. That's our minimum time that we want to do it for. Suggestion of cool running water. Okay, but in this case, the paramedics tell you that they've already applied their hydrogel cool packs for 20 minutes. So what do we think? We like the hydrogel packs? Yes, I think that's really reasonable to repeat it. There's no official guidance on whether we repeat it or not. The official guidance says hydrogel is pretty rubbish, or at least is not shown to be superior to cool water, which is highly evidence-based, as we say. So we definitely prefer cool water to the hydrogel packs. If it's not going to make the child hypothermic, I think it's pretty reasonable to offer them a bit of irrigation as well. What if they had 10 minutes of irrigation at home? Yes, I'd probably not. I'm reasonable to do a full 20 minutes again, but I would do at least a further 10 minutes. And there was a couple of other points being raised there. So one was about a bath. Yes, often that is going to be an appropriate way to do it. Officially, running water is preferred to a bath just because obviously a bath will warm up and cool water remains cool. We could talk about the practicalities of that for Vicky's benefit in a moment. But the other point that was raised was about cool water. So what does cool water mean? Ah. Does anyone want to suggest a temperature perhaps? Correct. So a key pitfall is not to use very cold water because we're not trying to cool the heat within the skin or anything like that. So around 10 degrees, not far off, probably an acceptable temperature to use. So the optimum is actually 15 degrees, 1.5. So if you think about that, that's really not ice cold. To me, that's kind of a fridge temperature. Well, I guess it depends what temperature your fridge is set to. And there's some allowance for a range around that, but that's kind of what we're aiming for. So it's kind of cool to lukewarm, I guess. It's certainly not very, very cold water exactly, Noella. So that's really important. In terms of practicalities, so it can be really, really hard because obviously the pitfall here is making a small child hypothermic. And if you have to choose between providing satisfactory irrigation or maintaining normal temperature obviously comes first. That's really important. So if you're making a child shiver and so on, you've gone too far and you have to either dial back or terminate your irrigation. Much more important to keep the child's body temperature appropriate. How do you do that? Well, clearly in large burns in small children there's a tension, and it might be that you just have to limit or not do irrigation, and that's just the nature of the balance and the importance of keeping the child's temperature appropriate. For burns where it's possible to localize your irrigation, the cool trick, I don't know if anyone's seen this, but I've used it a couple of times to good effect, is actually getting a large bag of fluid. So I'm not sure large bags of water exist. So I guess perhaps they do, but large bags of normal saline definitely do. And you can pop those in the fridge at an appropriate temperature to get it to around 15 degrees. And then if you just connect that to a giving set, you essentially have kind of a drizzly sort of water pistol that you can then direct over the appropriate area. And you pop either a receptacle or some Inco pads underneath the child, so they're not hopefully sitting in continuous cold puddles of water. And then you just let that drizzle over the appropriate area, and then you're applying cool, continuous running water and you're way on guidelines. So I found that a really useful trick. I don't know if anyone else has come across that. Okay, so I hope that's helpful about irrigation, because we all know that it's something we do in theory. And sometimes, as people have raised, the actual practicalities of how you do that can be a challenge. Oh yes, this is again a really important, although controversial point. So George, you're just asking how vital is it that it be cool? It's not completely vital. Off the top of my head, I think the BBA, which is the British Burn Association guidelines, talk about it being acceptable somewhere between 10 and 25 degrees, although I will double check that for you. So obviously you use what you have. That's just the ideal to aim for. The point I think is really important is that it still has value for the first 3 hours. Loads of people don't know that and will often push back on this. But if the burn has happened even 2 hours ago, it's been shown again from the models to have value. So even though it feels a bit silly because you're doing it hours after, still a useful thing to be doing, or still a useful thing to be topping up if it was inadequate at home. Just answer the questions that are being raised. Catherine, yes, so flow water preferred because it maintains its temperature, whereas if you sit in the bath, it starts warming up. That's the logic, at least. Again, you use what you have, though. Kate, saline to use, is it all right to use as irrigation? I think so. So the guidelines say water. I can't really see a problem with saline. I suppose you question whether the salt might make it more painful. Don't know. I've used it. Hasn't seemed to be more painful than water. And Sarah, yes, I guess echoing the point there. So Mel, I haven't seen it be more painful than anything else when I've used it with children. Obviously, the sodium concentration is low. If you have water in bags, obviously that's great, but it's not something I can claim to have seen in many resus units. Okay, so we talked about avoiding hypothermia, clean covering. And then, yeah, just another important part of first aid is elevating a significantly burned limb to try and reduce edema. Ruth, yes, I think sterile water would be ideal. Does it have to be? Could it be tap water? I guess it could. I mean, that's the first aid guidance for people at home, isn't it? So I think if that's what you have available, I think that's probably reasonable, and Woolwich agrees. Okay, and then just to remember, because again, it's a common question, antibiotics are not routine unless it's a clearly infected wound at time of presentation or it's on specialist advice. Okay, I'm not going to do lots of pathology diagrams. It's not that kind of session. The only reason this slide is here is to make clear that burn theory is that you, at the time of the initial burn, get an initial area of necrosed tissue that's dead. Can't really save that. You get lots of red skin, where blood is still perfusing reasonably well. In fact, it's increased, it's hyperemic. But then you get this yellow bit in the middle where blood perfusion is not excellent, and it's really vulnerable to all these horrible cytokines and mediators that are being released from the dying tissue. That is the bit you can save with really good first aid. So that is what we are trying to do to improve prognosis with things like irrigation. That's the pathology that underlies them. Promised you that would be brief. Okay, fluids we were talking about. Who wants to tell us about fluids? And again, if you're brave enough to turn on your microphone, that's always appreciated. Someone tell us about fluids. Yeah, so we're hearing the magic Parkland word. Yeah, agreed, George. So you don't need either of those just because you have a burn. And I wonder, George or anyone else, do you know what body surface area percentage of burns in this child would normally mandate Parkland's fluids? Excellent, Woolwich. Yeah, 10%. It's quite right. A higher percentage in adults, so don't get caught out. Yeah, and so lots of references to Parklands. Now I'll show my one and only fascinating fact about the Parkland formula. So what we use nowadays is actually the modified Parkland formula, but does anyone know where Parkland Hospital is and why it's famous? Brief tangent here. Good guess, Woolwich, but it's not right. Oh, way off, Christine, way off. I mean, maybe there's a Parkland there as well, I don't know. Yeah, excellent, Richard. Yeah, so it's quite right. So as it is where JFK died, it is, of course, in Dallas. It's a big public hospital in Dallas. And yes, it's famous for being where JFK died. And also Lee Harvey Oswald and Jack Ruby as well, interestingly. So that's our little sidebar for a little bit of colour there. But the modified Parkland formula is really tricky. So as well as irrigation, this is the other place where people, including me, often go wrong. I'd say it's probably the fluids which go wrong the most after DKA fluids because they're unfamiliar and tricky to calculate. So let's go through that quickly together. Firstly, why we're giving fluids, you guys have already alluded to the fact there's likely to be a big fluid requirement. Again, I'm not going to spend too much time on pathology, but we're seeing lots of leaky capillaries. We're seeing lots of protein leaking out into the interstitial space, big osmotic fluid shifts in particular, among other mechanisms that can cause a lot of, I guess, effectively third spacing of the fluid out of the vasculature. We've talked about the threshold for starting fluids. So modified Parklands, please refer to it because it is hard to remember. It's 3 mils per kilo multiplied by the percentage body surface area. And Hartmann's is recommended if you have it available, which I guess usually we do with a little bit of detective work. And then timing. So again, this is where it can get a little bit confusing. We're giving half in the first 8 hours, but not the 8 hours from now. It's the first 8 hours from the time of injury. So you might have to accelerate it to make sure that half of the Parkland amount is given by 8 hours from the time of injury. The second half is then given over the following 16 hours. That's an initial starting point. We're going to aim for a urine output of about 1 ml per kilo per hour. So this sort of intervention often goes hand in hand with a catheter if possible. So you might go up and down. And then also not to forget that this goes on top of usual maintenance. It's not instead of. Certainly for smaller children under about 30 kilos, certainly that should be the case that you're giving both. And the maintenance must contain dextrose. So I guess it would typically be your normal maintenance fluids, typically normal saline with 5% dextrose. And does anyone want to suggest why it's so important we give those normal pediatric fluids alongside? So why do we want to give our 9 and 5 fluids as well as Hartmann's? Interesting. Yeah, thank you, Charlotte. Thank you, Charlotte, for coming to the rescue. Yeah, so Hartmann's, remember, contains no glucose. I think I'm correct in saying that. So extremely important that we give some dextrose to children who are obviously generally vulnerable to hypoglycemia, and particularly so when they're under enormous metabolic and physiological stress. Thank you, Sam. Quite right. Great. Okay. And so Mel, you were asking, what do we do if they present late fluid-wise, i.e. after 8 hours? Ooh, good question. Well, so I think probably then we have to use our common sense. So I'm not sure there is any official guidance to answer that question. So obviously that's going to raise all sorts of other questions about why a child with such a significant burn is presenting so late. The point of Parkland is to try and get ahead of anticipated fluid shifts. So it's important to recognize that we wouldn't normally expect a child to be hypovolemic and enormously shocked from burns within the first hour or two. In fact, if they did present in the first kind of hour, significantly shocked, if this child was significantly shocked, we should be thinking about other things. Anyone want to suggest what other things we should be thinking about? Yeah, I 100% agree, Willett. So I think all these points are fair. I think it'd be unlucky to have coincident sepsis in a burn, but anything is possible. But certainly another traumatic injury and occult bleeding in particular would definitely be something to think about. So just coming back to your question, Mel, I think you're going to have to use your clinical judgment somewhat there. You're going to recognise that the child is going to have likely to have a significant fluid requirement already established. And you're going to have to use your clinical assessment to think how much above maintenance you want to give that. There may well obviously be a clinical requirement for bolus therapy by that point. Yeah, so Andrew, I agree. That may well be 20 ml per kilo fluid boluses, or if you're worried about things like bleeding, you may restrict those fluid boluses. Yeah, but I guess an unusual situation for this sort of burn to present that late, and I completely agree, raises major safeguarding concerns. And rhabdomyolysis, yes, Woolwich, I agree. Certainly, as we get into later hours, that might be something we're seeing. Certainly, if the urine is turning red or if it's dipstick positive, that's certainly grounds to increase your fluid resuscitation. Okay, tubes we've alluded to already. For the more significant burns, over 10%, you certainly want to be thinking about a urinary catheter, and also an NG. The NG, because this child's going to be at risk of an ileus, and we want to keep them nice and empty. Having seen patients overloaded and underhydrated, when would you switch to oral or NG fluids? So this sort of child is probably heading towards either an HDU-ITU environment or to the burn centre. So fortunately, that decision is likely to be for them. So there's going to be competing priorities, George, to answer your question. So on the one hand, we need to consider whether the child has an anticipated need for rapid sequence induction, and we want to keep their stomach empty. On the other hand, there's actually proven value to starting early enteral feeding in children, even when they have an HDU-ITU requirement. But although all of those are going to be decisions a little bit later down the line, and probably going to be left to the burns and intensivists. But it's certainly not wrong to start early enteral feeds, even in an intubated child. We just need to make sure we have a clear anaesthetic plan before we do that. I agree with your point. You have to worry about fluid overload. I think that underlines the point that the Parkland is a starting formula, and you're going to be reviewing that based on the usual parameters you would use, but particularly urine output, including a very high urine output, making you think about dialing back on the fluids. So the point is well taken. Okay, are we ready to talk about burn centres? And I need to involve clever specialists. Are we ready to refer this child? Yeah, I agree with all these points. What a silly question. Obviously, there are lots of things we need to do first. I agree. So you've told me about history. What things do people want to know from the history? Yeah, how, when? Yeah, clothes, really important. Yeah, so their background medical history. Yeah, so details of any fluid, that's really good. Yeah, how long it lasts for, all excellent things. And one of the reasons these questions are important, other than them being important, is anyone who's actually spoken to their local burn centre will know that you get taken very methodically through a form. It's a bit like referring to CAPS or STRS, and they probably will not accept the referral in its entirety until you've answered all their questions. And they include things like clothing being worn, first aid done at the time, as has been suggested, social concerns. Yes, I agree completely. I love how there are several teams from Woolwich coming in. Very impressive. Okay, great. So I think we've covered the main points. As always with the history, particularly where there's any safeguarding concern, it's the when, where, who, and how, particularly important for a case like this. How long was the exposure? Really, really interesting. So if you apply 60-degree water to an adult, it will take them over 20 seconds to get a full thickness burn. And unless there are special circumstances, the adult is obviously not going to tolerate that. So really interestingly, same kind of water, more than 20 seconds for an adult. For an infant, it takes less than 1 second to achieve a full thickness burn. So duration really important, and the age of the child really, really important as well. Details of the fluid people reference. So although it sounds weird. Things like, was there milk in the tea? Was there sugar in the tea? All these things affect the burning potential. They're often questions you'll be asked when you make the referral and then get sent back to ask the poor family again if you don't know. So good to get right first time. Clothing, yes, what were they wearing at the time? Was it removed as part of the first aid? I'm seeing some references to safeguarding questions, so it's great that you guys are picking that up. Tetanus prophylaxis, yes, so this is a perennial concern or question, at least in A&E, not just burns, but any skin break, whether people need tetanus prophylaxis. So official guidance, unless it's a particularly exposure-prone, like soil-covered contamination, is that normally the primary course of immunization should cover things. Even then, I think it's common practice that if that's incomplete, that's often accepted unless it's a particularly dirty wound, but officially they do need revaxis if they don't have their primary immunizations. I agree there needs to be a real emphasis on safeguarding concerns. That's what I was referencing with anything else. So that's going to be a key thing to think about. But we know safeguarding, so I'm not going to dwell on that. Are we ready to refer now? No, because people were talking about photos and assessment as well. So let's talk about assessment. So assessment, what we're getting at there is the percentage body surface area and the depth of the burn. Again, causes a lot of confusion. Let's talk about percentage. First of all, there are several ways to do this, and we're forever hearing that one way is the wrong way and one way is the right way. In a way, they're all the right way, so long as you know what you're doing. So firstly, using palms, yes, totally fine in all age groups. It just has to be done the right way. So that's using the patient's palm, their adducted fingers and thumb. It's the patient's palm, not your palm. That equates to 1%. So that's one way to do it. Often not a terribly practical way. So then we have the rule of nines, which, as the official rule of nines, can only be used for adults, but can be adapted either arithmetically or with specific charts, which are called London browser charts for particular ages, and adapted, and we'll look at that if we have time in a moment. But finally, Mersey burns. I love that was one of the first bits of suggestion we had in this session. If we had a video, I would wave it up at you, but for anyone who doesn't know, this is a great free app available for both iPhone and Android. It basically lets you do colouring in on a little avatar of a child or an adult, and then we'll work out the burn for you. Remember that what we're interested in is the area of at least dermal burns. We'll come to what those are in a moment. So simple erythema doesn't count. Okay, so we're looking for essentially blistered or leathery skin. And Parav, I hope I've answered your question about things that make a fluid sticky or cause it to keep its temperature for longer will increase the burning potential. Depth of burn, so that's just a slide from Mersey Burns to give you the idea. Great app, download it now. Useful to have when you need it and don't have a Wi-Fi connection. Depth of burn, again, really confusing. There's loads of different terminology around. The Americans talk about first degree, second degree, third degree. We've changed our terminology in the UK in recent years. They keep adding different kinds of burn. In fact, I had to adapt this slide to include mid-dermal because that was a relatively new term that not all the guidelines use. We don't need to overcomplicate it. What we're getting at is which layer of skin we're talking about, just the epidermis. We're talking about kind of things like sunburn there. As far as the burn centres are concerned, doesn't really count for them that much. They tend not to be too fussed about it, and that can typically go home. Then things that get into the dermis, so that's the deeper layer where epithelialization, that's how to say, comes from. And that can be either a superficial burn that's just involving the dermis. It can be a deep burn that's going almost all the way through to the subcutaneous layers of fat and fascia. That's important because that might destroy the centers which allow healing and allow epithelialization to take place, so things like your sweat glands and hair follicles. Or it might be the even deeper kind of deep burn, which is a full thickness burn, which is actually extended into those subcutaneous tissues. So one way to think about it is superficial, just simple erythema, deep burn, so your deep dermal and your full thickness, and then things in the middle, which are mainly involving the dermis and which might have signs in between the two. So talking about those signs, epidermal burns, that's your sunburn. So as we all know, it's red, it's very painful, but it displays cap refill. This slide talks about blanching. I'm sure that's true, but I would advise using cap refill as your distinguishing feature rather than whether it blanches per se or not. So good brisk cap refill and epidermal burn. Superficial dermal burns likewise retain their ability to show good Capri film, but the hallmark is that they show mottling, so excuse me, they show blistering. All those blisters might already have broken, the skins are rolled up, as you can see in this particular slide. When we get into deep dermal burns, so remember that's the first kind of deep burn, that has kind of a beefy appearance to it. It might still be blistered, but the key is that you're losing your sensation and you're losing your brisk Capri film. And finally, full thickness burns, similar signs, might actually look white and quite leathery as well. As a final exercise, I can let you guys do this at your leisure after the session. You can have a little exercise working through an actual fluid prescription. It takes a few minutes, so I won't get you guys to do that now, just so we can come to a nice timely end to the session. But it's a really good piece of homework to do, just because I think when we do this in real life, I don't know about you, but I feel quite uncertain whether I've got to the right answer or not. So it's nice to have an example you can actually check through whether you've got to the right answer or not. And I'll quickly skip through the answer slide there. But are we ready to refer? No. As you told me, we still need photos. So great if we can do all these things in one go. So our assessment, our photos, and our debridement of any blisters as well. Do all blisters need debriding? Essentially, yes. So unless they're really tiny, like less than about half a centimetre, they do need debriding. Sometimes there's some debate about ones on kind of the fingertips and things like that, but the burn centres tend to say all larger blisters should be removed. Certainly any loose rolled up skin should be debrided. There's some good guidelines on the Burns Network webpage, which I will give you, as how you actually do the debridement, and often the nurses are excellent at this, but it's a really useful thing to watch being done and have a go at yourself. Remember that blister tissue, although it looks like a horrific thing to do to a child, it's completely devitalized tissue, so cutting into blister and so on should not be painful. There's some really good pictures and so on the Burns Network webpage. The ideal technique is to use some gauze and vigorously rub the blister skin to remove it. Kind of bigger, more tense blisters sometimes need cutting using tweezers and scissors. Again, if not, it's devitalized tissue, it shouldn't be painful to do that. Having said that, if you're scrubbing a child's burnt skin, that of course could be sore because of the vitalized skin that lies underneath it, and they may need good procedural analgesia when you're doing it. Clingfilm, this, to be clear, is the incorrect technique. There's quite a few reasons why this is the incorrect technique, but one of them, and Christine, I'll come back to your question in a moment, one of them is that, again, another key pitfall is that people often apply the Clingfilm circumferentially. What you should be doing, for obvious reasons, we don't like circumferential dressings, particularly over swelling bits of the body, is applying strips of Clingfilm. That is their preferred technique. Christine, I think your question is, it's surprising that debriding the blister tissue like an intact blister, it's surprising that's recommended, because you might think that leaving the blister intact would be a better way to contain infection. And I agree, you would think that, and that's often the folk wisdom, and it surprises parents. But the feeling is that a blister actually becomes a locus of infection, so they can get blistered within them. They tend to release at some point anyway, and then you just have lots of devitalized tissue lying all over the place, and that's a definite locus infection. And they can also get quite painful if they get tense as well. Okay, finally, referral. This is really well covered in your local Burns Network guidelines. I won't spend too much time on it. They're really, really broad. I find a large majority of all burns I see qualify for referral. Note that significant burns are more than just superficial. Greater than 1% qualify for referral. Face, hands, genitals, feet, joints, scalp, and ears is quite a large part of the body surface area covered already, in particular. So remember that hands are in there, because obviously that's a common site infection, and technically that requires referral, at least board discussion. Okay, everyone likes getting the digital camera out of the CD cupboard to send on trips. For anyone who hasn't used it, that's a website for sending photos securely. Sometimes also use plastics cases as well. You can register, I think, with your NHS webmail account, and it's quite quick and easy to do at the time, or do it now, so you're all registered. It's pretty self-explanatory to use. There are some pitfalls, even in how you take photos. I would recommend, for speed and convenience, send a TRIPS referral and then make your first calls to the centre, because otherwise I'll just ask you to call back after you've sent the photos. Anyone want to suggest what's wrong with this photo as a TRIPS photo? Excellent. So that's, thank you. Brilliant. Dr. Luong and Leila, those are the key points I wanted to raise. I think everyone else is echoing you. Yeah. So what the receiving centres don't like is visible blisters, because they will just tell you to take all your dressings off, deroof the blisters, and then take pictures again so they can see what's underneath. That's another reason, I guess, to answer the question about why we debride blisters, is because you can't assess the depth of the burn underneath it in terms of things like cat refilm until you've deroofed it. So yes, what's wrong with this photo is the blisters should be deroofed to show what's underneath. And secondly, it's not clear what body part this is. It's a shoulder, anyone who wanted to know. So they often like a wide angle photo showing where on the body it is, and then some close-ups as well. Okay, and finally, because I know we're coming to the end of our time, this child comes back 36 hours later. They haven't been quite right, families say, and also they have developed some diarrhea, which wasn't a huge surprise because it was going around the family. Anyone want to suggest what might be going on and what needs to happen? Yeah, brilliant. So I love that we're seeing 1,000. I can't get one past you. 1,000 references to toxic shock. Yes, cat, so sepsis indeed. Might not be toxic shock, but toxic shock would be the flavour of sepsis, or at least SIRS, that we'd be particularly worried about. I've linked a really useful review article on that, because it's not my main focus today. But essentially, kind of a cytokine storm as adults are seeing COVID patients that makes patients very, very ill indeed. Typically staph or strep, but can be other bugs as well. So Referral, clindamycin is a sensible antibiotic to be thinking about, but be guided by your local recommendations. I won't dwell too much on that. Good resource linked to. So Catherine, it will be in the final slides, which I will circulate, but it's also coming up in a moment, the link. Okay, so to that end, when you're sending a child home, if they don't need transfer, and this child probably will be one who needs transfer, if it was a smaller burn, you're going to safety net, yes, for signs of local infection, but also for toxic shock. That's really, really important. We often don't do that, and we really should. There's a really good leaflet on the network page, and again, I'll give you the link to that network page in a moment, which is a patient advice leaflet that talks about all those things. Dressing changes. So initially, we like to review burns at around 2 to 3 days. We're looking for signs of infection. We're reassessing, did we get the depth of the burn correct? General advice, people always ask you about scarring. As you'll know, it's difficult to prognosticate. In particular, burns, scars in general often look worse in the first year and sometimes fade after that point, which is important to know about. Important for people once the burn is healed to use sun protection, so cover it up and or use sunscreen, and moisturizers can be useful as well. Why did I say this was a useful pandemic PTD presentation? Well, I don't know if you guys will agree. You can message whether you think it's a yes or a no. We know that most burns happen in the home. We know that most burns in kids are scalds. And it's strongly believed that burns have always been linked to things like social deprivation, social stress, family disruption, and so on. I've certainly seen quite a few in the last couple of weeks, as I very much expected to, and I'm curious if that's others' experience as well. But given that numbers are down, but this is something that seems to be up, I thought that might be a useful thing to refresh on. My take-home points, because I think we're at time, and I'll then open it up to questions and maybe a slightly more complex case for anyone who wants to stay in the session. The take-home points at the end of our hour is, firstly, I think it's really valuable to have some kind of system for preparing for blue calls. And I've suggested the PEDS mnemonic as one to use. So I hope people find it useful in general. It's not a burn-specific thing. The importance of analgesia, I agree with everyone who insisted it should be a priority, perhaps in parallel with your primary survey. There's lots of ways to get irrigation wrong. There's lots of ways to get your fluid prescriptions wrong. So I hope the teaching slides on that have been useful. There's a good example to work through on the fluid calculation. You guys were completely on top of the NAI angle, and that's something the burn centres will always ask you about as well. And remember that vigilance to toxic shock, which again, everyone shouted out pretty immediately. Anyone who needs to go, please feel very free to leave the session now. But for those who'd like to, I'm just going to run through a very quick, more complex case and open it up to questions, but feel free to leave if you need to. So the slightly more complicated case, there's been a HEMS call. So perhaps you're not a trauma centre, but for whatever reason, the HEMS service are bringing in a child by land as you're the closest unit, and they felt the child needed pretty urgent attention. It's an 8-year-old boy who's been in a house fire. There are a couple of adults there as well who've been taken to other hospitals, and the only information on the blue call is that his GCS is 7. So again, this would be a great time to repeat our PEDS mnemonic for preparation, as I'm sure you would tell me if I asked. And I'm sure you'd also tell me that you're going to go through his primary survey. And you find that, well, he's phonating. He's really just making noises more than words, but he is making noises. He's getting air into his chest pretty well. He's saturating really well as well. He seems hemodynamically normal and stable. And you've got, of course, because of the HEMS team, really good IV access in situ, which you test yourself, and it's working well. But HEMS are right, he's only a P on the AVPU. He does have leathery burns when you expose him to his chest and his neck, and he's got soot around his nostrils. So would anyone like to suggest, again, feel free to use the microphone, although I know you won't, but feel free to use the microphone to suggest what your priorities might be and what your thinking is.
I think you most have airway concerns, even though from the initial odds, the airway seems protected. There's obviously potential airway damage from the soot around the nostrils, and then also potential for carbon monoxide poisoning.
Yeah, fantastic, Lauren. Thank you so much. So in case anyone didn't hear, I think that was Lauren speaking, and brilliantly summarised 2 big concerns here. So firstly, the need for airway support. And I guess we've got 2 reasons, as you said, for worrying about that. There's the suggestion of hot gas inhalation and the fact that they've got burns encroaching on their neck. And then also the concern about carbon monoxide poisoning. So in a way, the carbon monoxide poisoning is perhaps presenting itself more immediately than the airway impairment. They don't seem to have airway impairment at the moment, although I agree with you, we want to get ahead of the aeroplane and intubate them early in this situation. But carbon monoxide poisoning is definitely something we need to be worried about right now, and that might be an additional reason for intubating them nice and early. How are we going to know if carbon monoxide poisoning is the cause of their reduced GCS, their obtundation? Yeah, so Capta immediately said blood gas. Yeah. So I think what's great to draw out from this is the fact that you do get a carboxy hemoglobin level on a blood gas, which is something I think a lot of us just don't look at routinely. And I guess perhaps routinely we don't need to look at it, but in any child with reduced GCS, just moving away from burns and trauma completely, any child with reduced GCS, obviously particularly where it's unexplained, that's really something we should be looking at. And, you know, I've certainly heard of cases, if not come across myself, of people who've made it to IT or PICU with unexplained coma, and it's been quite a late pickup that someone's finally spotted that abnormal reading on the blood gas. Just to prove it to you, there it is, hovering under the oximetry values near the bottom as your COHB. Normal in a child should probably be very, very low, like probably less than 1%. But we probably accept it less than 5%, I guess, if they're in a really smoky smoker household or something like that. Already smokers often have high levels. But certainly once you get above a small number of percent, 3 to 5%, certainly you want to be applying high flow oxygen. I won't get into hyperbarics and so on, if only because it's rarely actually going to be a practical consideration. You clear your carbon monoxide pretty rapidly with high flow oxygen, and probably more quickly than you'll get someone to a hyperbaric chamber. I think you guys all know that patients will often have high transcutaneous saturation readings. The sensor usually can't distinguish between carboxyhemoglobin and oxyhemoglobin, so you get a falsely high reading on that. So don't be swayed by SATs 100%. Also, don't necessarily be swayed by the carboxyhemoglobin level on the gas actually being not too bad. If the child is really knocked off with no other cause and the level is slightly elevated, it may well be that it was much more elevated earlier and it's just come down slightly, either with time or with oxygen treatment en route, and it might still be your explanation as to what's going on, although be vigilant for other causes as well. If it becomes fistulous, well, you've already told me that you're keen to anticipate, you're keen to intubate probably before that happens. Let's say you get them on the vent, but they're difficult to ventilate as our final question of the session. So you have a child, and I'll remind you of their presentation here, who's on the vent. You've avoided that pitfall of not tubing them nice and early. You've got them tubed, and they suddenly become difficult to ventilate. What are people going to do? What are you going to think about? Yeah, thank you, Vicky, my ever-leader picky buddy. All those suggestions are excellent and correct, and you've picked up what I was hoping to pick up immediately. But let's not forget, just as with our primary survey, let's not get distracted from first things first. So we need to think about common causes of suddenly having a problem ventilating. So yes, you're going to want to get them onto water circuit, bag them by hand, and work through your dopes. So for anyone who doesn't know, thinking about a displaced tube, an obstruction of the tube in pneumothorax, an equipment issue, which hopefully you isolate by putting them on a hand circuit, and aspirating their stomach as well. But yeah, what I was getting at is, assuming you've worked through all those things, with leathery burns to their chest, it may well be, as well as a suggestion that they might have a lung injury, this might just be a soft tissue problem, that their skin has essentially lost its ability to expand, and their chest can no longer expand, and that's why it's difficult to ventilate them. The solution to that is an escharotomy, which is one of those things you never really want to do, and I've certainly not done it. I'm not going to suggest I have. But even though it's probably not something we ourselves might be doing, and we might well be getting our surgical colleagues down in a hurry, it's important to at least know the process and know how to support it. And I suppose it might even be the case that we might have to do it in desperate circumstances. There is guidance. Your burn centre will guide you on how to do it and supply relevant diagrams and so on. I'm not going to go into detail, but the idea is that you're releasing the skin with cuts in very specific places that avoid superficial structures. It's not quite the same as a fasciotomy. A fasciotomy, you're getting down to the fascial muscle compartments. Escharotomy, you're just splitting the skin layers down to the subcutaneous tissues until the skin comes apart. Apologies for the horrific slides. These are actually the least horrific ones I could find, believe it or not. There's specific guidelines which your burn centre can provide with diagrams about where you cut. No, I've never got close to one either, Catherine. I hope I never do. Would you call surgeons get on with it? This is one of these things like medial canthotomies and resuscitative cesarean sections that we hope we never have to do. And I'm not sure there's a blanket answer. I think it depends on the acuity of the situation, how quickly you can get people to help you. I very much doubt your on-call surgeon will ever have done one of these before. Either it is a scalpel technique, hopefully in an intubated patient, but that's probably the best answer I can give you, unfortunately. Was there anything else I was going to say about escharotomy? Probably, but I'm conscious of time, and I will link to some resources which go into more detail on it. Here, as long promised, features obviously even one in South Africa, everything in South Africa. So yes, I think would be at least calling for their assistance if they were available in terms of surgeons and plastics. So lots of good resources, which I think are genuinely useful resources, and I'd suggest you do have a look at. The Burns Network page is great, loads of really, really good stuff on there, loads of pictures, loads of one-page guidelines on how you do various things around burns. Do have a look. In terms of child protection, there is a child protection evidence-based review specifically around burns on the college website. Some good blog pages, EM3 has some good resources, some of which I have borrowed and some of which I've edited for this talk. The Mercy Burns app link is there. That BMJ article is a review article on toxic shock, and particularly in children. For anyone who's interested in burns, I cannot recommend enough the EMSB course. That's the Emergency Management of Severe Burns course. It's run in Chelsea and other locations, and and I did it. So it's certainly worth applying for one of those. So if you're interested in burns, that's a great way to build upon it. Firstly, I'm very keen to let people go who want to go, so please feel free to go if you're needed on the wards and so on. If anyone would like to ask any questions, you are extremely welcome. And I'm really glad people found it valuable. Thank you. Any questions, hit me up. So firstly, thank you everyone for the very nice comments. That's really appreciated. I really hoped it would be useful and perhaps something that's not taught that much to us paediatricians. George has a question about so maybe 10% of burns have a safeguarding component. Should that mandate further safeguarding discussions? So that's interesting. I hadn't seen that article. That's really interesting to hear about, George. Thank you. Well, certainly my practice is no, and I suspect that's most people's practice. I guess you've got to drill down into that data, and it's specific burn types that are falling within that 10%. We all know, glove and stocking burns, bottom burns, that sort of thing, as ones that trigger particular concern. Is 10% that different from the percentage of all injuries which, when pursued, have a safeguarding component? I probably doubt it. I don't know, but I probably doubt 10% in a way. One sounds quite low. Certainly my practice is not that all burns get referred. I'm quite trigger happy on copying a notification to the health visitor in any accident in the home, particularly where there's a failure of supervision component. So that certainly is something I would strongly consider. And remember, that's just a notification. That's not an accusation. That's not a request for investigation. Reaper, so I hope that answers your question, George. So I'll try and work through these questions. Apologies if I miss one or I don't have them in order. So Reaper, you've got a question about SSD, sulfur-diazine. Fionwala, hope I'm saying your name correctly. Any differences for chemical burns? So let's take chemical burns. So yes, it was the answer to your question. That's probably a topic in itself. But the main things I flag up in 10 seconds are firstly that it's a much longer period of irrigation, sometimes even up to an hour, particularly for alkalis. It's important to know what the chemical is for that and other reasons. But the other important factor is toxicity. So as well as the local burn, chemicals, of course, can often cause systemic toxicity. So it's really important to know what you're dealing with. And as well as getting help from the burn centre, remember that you can also get help with chemicals from the National Poisons Information Service as well, and you should. So they are complicated and specialist, but in particular you want lots of irrigation. It can all get very complicated. If things are dry powders and so on, then you want to brush those off before irrigating, but it's probably a session in and of itself, and an interesting one. Reaper, you asked about SSD silver dressings. There is a role, but probably not in the acute setting. That's often a bit further down the line, and often something the burn centre will put on if they feel it's indicated. Obviously, if they tell you to do it when you speak to them, that's fine. But it's typically not a primary dressing that we put on by ourselves. We'll normally use a non-adherent dressing in the acute setting if we're not just using Clingfilm, so things like Mepitel. There's a million, but probably whatever your department uses. Catherine's got a random one, so I know it's going to be good. What is worst sunburn you've ever witnessed or heard of? I probably have to say mine on holiday a few years ago, because it was just insanely itchy and horrible. But yeah, you do hear stories of people getting full body sunburn and so on. So I can't say I've seen particularly bad cases of sunburn. As I say, official guidance is that sunburn typically will be superficial only, and therefore, I guess the implication is that even if it is very high body surface area, it still is a chance you can potentially go home and will need to use a lot of moisturizers and potentially things like anti-itching medicines like antihistamines as well. Obviously, there is, I would feel, something of a safeguarding component to that, although everyone makes mistakes in the sun. Can sunburn be worse than that? Probably. I don't think it's a law that sunburn can only be superficial, just that it's the classic example of superficial burn. So you have to assess it as you would any other burn, particularly thinking about things like blistering and cap refill. So I've definitely seen blistered sunburn. And then, of course, you are dealing with more than a superficial burn, and you need to manage that accordingly. So I think just apply the same principles we've talked about to sunburn, and you won't go far wrong. Let's see if we've missed any other questions. Decision for antibiotics. What will be running through your head? So I think the main point, Abdi, is just that it should not be the case that you see a burn and you go, oh, that's a bit grotty, or the skin's broken there, let's start some antibiotics. So the only good thing you can say about burns is that they're self-sterilizing. So the idea is that, the heat sterilizes the burn when it's made. So we don't consider them immediately prone to infection. The BBA would say that if the burn is clearly infected at the time of presentation, so I guess the implication is it's a somewhat delayed presentation and it looks infected, or if the context is such to give a really elevated suspicion of infection, so I guess it somehow got really, really dirty initially, that might ground a decision for antibiotics. Admittedly, you rarely do that much harm with some augmentin, but it really shouldn't be a matter of routine. And I certainly very, very, very rarely given augmentin at the time of first presentation to a burn I've sent home. And to be honest, I've rarely started IV antibiotics, even on the sicker ones that I've had to transfer. It would be only if the specialist told me to. So I hope that answers the question.